This program is brought to you by Emory University.
Good morning, everyone. Thank you for joining us on this Friday after Halloween. This morning we have Sophie Vitter, who is a Louisiana native and was an Emory resident and stayed with us for fellowship. She is going to be talking about cardiac papillary fibrolastomas, and we are excited to hear her talk. So Sophie, take it away.
Thank you, Dr. Coley. Appreciate it. First of all, I hope everyone had a nice Halloween yesterday and had some fun relaxing with their families and got some candy and all that good stuff. Now we're here for a new month, so welcome. I'm doing my fellows talk on cardiac papillary fibrolastomas, as Dr. Coley said. It's a little bit of a mouthful, so often I'll refer to them as PFEs, which is a common acronym for them. So I want to start with the objectives. And those objectives first to review our understanding of cardiac papillary fibrolastoma, which is a rare cardiac neoplasm, to evaluate how they're viewed and diagnosed on different imaging modalities, to examine the potential cardiovascular and systemic complications that we can see from them, and then to discuss the proposed management options. So next thing that I want to start with is just a very, very brief condensed case. And this is a real case that Dr. Clemens actually brought to my attention that happened at Emory a few years back. It's pretty interesting. So Mr. CP is a 68-year-old man with hypertension, chronic tobacco abuse, alcohol use, peripheral vascular disease, and remote bilateral DVTs. He comes to the ED after he was found to have right-sided facial droop and dysarthria aphasia. So, this is a pretty classic ED presentation. Of course, a stroke alert was called. He underwent a CT of the head that showed a distal M3, M4 occlusion consistent with ischemic stroke. He also got an MRI, and that ended up showing a hyperacute ischemia infarction without evidence of hemorrhage. So they didn't think he was a good candidate for thrombectomy given his distal disease, but he underwent TPA therapy. So all of this is pretty standard in a stroke workup. As you can probably guess, the next thing that's going to happen is that they're going to get an echo in the routine stroke workup, and we're going to end up taking a look at that. So this is one of the first images from that routine echo. This is the parasternal long, as you can see. And so, you're looking at it. It looks okay, good squeeze, but you kind of see something there in the LV, and kind of thinking, okay, that looks like something a little weird down there floating around, but let's try to get a better look. And so here is a still image that you can certainly much more clearly see that there is something right there in that LV. And then it ended up being this 1.4 by 1.2 centimeter rounded mass on the tip of the anterior lateral papillary muscle, as you can kind of see, and it kind of oscillated around. I think I have a picture of that. Here we go. You kind of see it just flowing around there, and you see the color going all around it. So here on this view, you can really, really see it just jumping around. And so, as you might have guessed, that ended up being a papillary fibrolastoma. And so this is a view that I just thought was really interesting from the TEE that they ended up doing next. And you can really see it really well here. It's a beautiful view where you see it just attached right there. You see that it's probably attached to a little stalk right there, and it is really kind of free floating around in that LV. So as you can probably guess, CT surgery was consulted to evaluate and offer surgical recommendations. The patient was deemed suitable for LV mass removal and required close attention prior to surgery. He underwent an LV mass/tumor removal with a right mini thoracotomy with conversion to median sternotomy by our own Dr. Dinishmand. And he did very, very well post-op. And then on an echo 1 year later, there was no residual tumor seen. And clinically, he was apparently doing great. So this is kind of a classic presentation echo to management of what might happen when we see a PFE. So that kind of brings me to the topic, cardiac papillary fibroelastomas, and let's get into a little more detail about them and kind of what they are. So first of all, what is it? A cardiac papillary fibrillastoma is a very rare primary cardiac neoplasm. Although rare, it's the most common valvular tumor of the heart and the second overall most common tumor of the heart, accounting for 10% of all cardiac tumors. It's said to be the second most common after cardiac myxomas, of course. However, in this very careful review of 16 years of patient data that was done at the Mayo Clinic, they actually said that PFEs were documented to be even more common than myxomas. So sounds like they're neck and neck. I don't know, that might be controversial, but it's either number one or number two along with myxomas. So in the past, they were usually discovered as an incidental finding at autopsy, and that likely reflected underdiagnosis and a relatively benign course in the general population. But now that we just have so many advances in imaging, specifically in echocardiogram, they're now more frequently being diagnosed pre-mortem, and we're learning a lot more about them. So who gets these tumors? Really, the short answer is anyone. They've been seen in neonates to 92 years old. The most common age of diagnosis is somewhere in the 60s. There's roughly even distribution between men and women. Our data shows 55% male, 45% female, so pretty even. And again, like I just said, because that up until very recently, the large majority of these PFEs were only identified post-mortem, the true incidence is really unknown, and it's hard to get really accurate epidemiological data because we're still learning a lot about them. So as time goes on, I'm sure we'll get some more accurate data on really who they are most likely to affect. Great, a little bit about where they occur. So they have a really high propensity to affect the aortic valve, the mitral valve, and then of course other places. So in a really large literature review where they looked at like 110 PFEs seen by echo, 49 of them, meaning 44.5%, were on the aortic cusp. So that's clearly the majority. Just of note, 24 were on the right, 6 on the left, and 19 on the non-coronary cusp. Unclear exactly, what to make of that, but they're seen on all the cusps. And then 40 of the tumors were on the aortic side and 9 on the ventricular side. So the next most common was the mitral valve, and 40 tumors, so 36.4%, were on the mitral leaflets, 23 on the anterior side and 17 on the posterior, with 32 on the left atrial surface and 8 on the left ventricular surface. And then finally, the remainder could be found anywhere, but often they're either in the LVOT or the LV septum. So, of course, they're most commonly found on valves. Approximately 90% of the PFEs reported in literature were attached to valves. And as I said on the previous slide, the majority of those were on the aortic valve. So for the aortic valve, just getting into a little bit more about aortic valve PFEs, there appears to be no clear predilection for the tumor to be on the aortic or the ventricular side in multiple studies. It can really occur on either. Now, the mitral valve is the next most common location, and tumors occur on the anterior or posterior leaflets, the chordae, the papillary muscles, really anywhere. And when an AV valve, such as the mitral valve, is involved, the tumor is most often found on the atrial side. And that's consistent with what the previous data had showed us, where 32 were on the atrial side and 8 were on the ventricular side. We don't really know why that occurs, but that just seems to be what the data shows us. And then along that valve leaflet of the mitral valve, the most common site of occurrence was in the mid portion. So away from the free edge and away from the annulus, kind of right in the middle. And then, of course, there's occasional reports of tricuspid or pulmonic valvular PFEs as well. It's likely that the lower rate of right-sided detection is due to lack of symptoms from right-sided embolization and underreporting, probably because, it's much less common for us to kind of investigate and excise right-sided valves or enter into the right heart, whereas the mitral and aortic are much more likely targets. So there could be even more of these tricuspid and pulmonic ones that we just don't know about. A little bit more about where they occur. Although valvular are the most common sites, really they can be reported almost anywhere. The left atrium, we've seen them in the left atrial appendage, the septum. right atrium, right atrial appendage, eustachian valve, Chiari network, right ventricle, chordae, papillary muscles, the ostium of the RCA or the ostium of the LCA, which you can imagine could be a problem. So anytime you see some kind of strange small cardiac mass on echo, you really have to consider a PFE because they can be almost anywhere. Okay, so a little bit more about what they look like on echo. So you saw in the case, you saw that kind of little round thing on a stalk floating around, and that's very characteristic of what they look like typical echo features. The tumor is round, oval, or irregular with well-demarcated borders and a homogeneous texture. Often it has kind of a speckled pattern with characteristic stippling around the edges. And that stippled pattern around the edges correlates with the papillary projections on the surface of the tumor, which you'll see in a few slides. Most of them are small. In recent study, 99% were less than 20 millimeters in the largest dimension, but some are certainly larger. And of course, the larger ones we're more likely to see on echo. And they can be single or multiple lesions, and they're most often associated with cardiac valvular disease. So these are just a few pictures from echoes that I just wanted to kind of show and discuss. So on the left is a PFE attached to the aortic side of the non-coronary cusp of the aortic valve. And this is seen on TEE in the mid-esophageal short axis. And you can clearly see that little round thing attached there. And then on the right is another TE that shows a mass on the aortic valve that was found to be a PFE. And you see it right over there going out into the aorta, probably attached by a tiny stalk there. So here's just some more pictures. Top left is a PFE on the anterior leaflet of the mitral valve. And you can kind of see it there. It's not as obvious of a little stalk. It's not as kind of mobile and out there, but you see something attached to that leaflet. And then the bottom right is echo showing a mobile spherical mass attached to the anterior mitral leaflet on the peristernal lung and the apical forechamber. And so you can kind of see the little round thing right there. So now I just want to get into a little bit of a differential diagnosis for these things. So the problem, like I said, that the echo findings are kind of nonspecific. So that means that when you see one, you really have to think of a lot of possibilities. So different things that we would think when we see something like we saw in the previous echoes is another primary cardiac tumor, like a myxoma, metastasis from somewhere else. And of course, that would most commonly be coming from cancer of the breast, a melanoma, hepatocellular cancer, renal, or a sarcoma, things that metastasize to the heart. A vegetation, of course, a non-bacterial or merantic endocarditis, a thrombus, a Lambel's excrescence. Maybe it's just a valvular calcification that's not really actually anything. And, on some of those other ones where there's not as clear of a stalk, you can definitely see how you could confuse that for just a little bit of a calcified valve, especially if it's a very small PFE. And honestly, a lot more. So there's a lot of things to consider when you see something that could be a PFE. And so just to kind of drive that point home, here's a few more pictures to kind of show you how easy it would be to mistake a PFE for something else. So the top left is an echo showing a mobile aortic valve vegetation from a patient who had, I believe, gram-positive bacteremia. And then on the bottom right, you can see an echo showing a mobile aortic valve vegetation that ended up being a PFE. And so if you compare both of these, I mean, you certainly can see that they're pretty similar. You could see that one would look like the other or not. If you really look, the PFE is a little more round, which is helpful. But certainly you can see how you could confuse these two, and they look fairly similar and are located in the exact same spot. So something to think about. And then here's another comparison. On the left, this small echo density on the anterior aortic valve leaflet is a Lambel's excrescence. And then on the right is an aortic valve PFE. And these look remarkably similar. So that's just another thing, those I think are really, really hard to differentiate, and something you need to think about. Is this a Lambel's? Is this a PFE? Which one of those you might be seeing, because those can look remarkably similar. And really any of the differential things that I mentioned, they can all present and look similar to PFEs on echo at the very least. So now a little bit about the gross appearance that I mentioned we'd be talking about. So they have a characteristic frond-like appearance, and they're said to resemble a sea anemone, which you can kind of see here in the pictures. They're actually quite beautiful when you look at them, and you can kind of see them looking like a little sea anemone. The fronds are best seen when you immerse the tumor in water. And they're commonly like an opalescent white color, but often this color could be masked by thrombus that's attached to the tumor. And then a little bit about the histological appearance. The surface of the papillary fibroelastoma is covered with like numerous filiform projections. And then there's this intermediate layer of loose mucopolysaccharide-rich connective tissue sandwiched between the outer endothelium and the central core. And that forms like a concentric granular pattern consisting of layers of fibrin and acid mucopolysaccharide matrix. So, when we excise them, when we look at them under the microscope, or at least our pathologists do, this is kind of what we see. And this is another picture that I just thought was really interesting, that shows a PFE of the aortic valve with papillary configuration and an avascular connective tissue core lined by a single layer of endothelial cells. So this really gives you a good idea of what you would see under the microscope. So one of the biggest questions that we have is really, why did these tumors occur? As I mentioned in one of the very first slides, they are benign, they're not malignant. But where do they come from? Why do they occur? Why can they really occur in people of any age? People without coronary disease, without other valvular problems. What's the answer? And the answer is, I don't know. The answer is that really none of us are sure why they occur. Research has yet to identify a precise like pathophysiological mechanism. Of course, this is probably because they're becoming more and more easy to detect as we have better imaging. So before, where we probably had very few examples in years past, we now are getting more of them in the recent years. So it's a relatively new thing to kind of look into. So we still have time to kind of figure that out. And then, just we don't have as much data as we do on other kinds of tumors and other cardiac abnormalities. So of course, there's a lot of theories. The most commonly accepted explanation is that these lesions are an acquired entity. And they begin as benign microthrombi, which then join at sites of just like minor endothelial damage on valvular surfaces. So over time, these microthrombi evolve into excrescences, and eventually they make PFEs. And then these PFEs continue to grow and can potentially embolize, causing resultant complications like stroke, MI, VFib, sudden death, and things that we'll get into. So I think that explanation makes a lot of sense. It's not necessarily like a metastatic growth, but more a process that kind of happened gradually. Another similar theory that Dr. Clements mentioned to me that I believe one of his colleagues had kind of come up with is that it's very similar to this one, but kind of that the linear collagen fibers on a regular valve will break, and then that broken fiber kind of extrudes and becomes endothelialized, and then that becomes the PFE. So again, that's similar in that, it's not necessarily a big abnormal growth or tumor, but something kind of that happens over time to the normal valve material. All right, diagnosis. So as we kind of talked about before, echo is the best diagnostic tool. First a TTE, and then of course a TEE for confirmation and to better identify the tumor's precise point of attachment. The sensitivity and specificity of transthoracic echo for the detection of PFE greater than 2 millimeters are 88.9% and 87.8%. So it's pretty good. As long as it's a decent sized one, it's pretty good. However, given their small size, their mobility, their lack of calcifications, they're pretty difficult to detect on cardiac CT. So when you see them on a CT, they might look like a small hypodense mass with irregular borders attached to a cardiac structure by a stalk. similar to what they look like on echo. The mobility of the tumor can be assessed with like EKG gated imaging, which can be helpful because you can kind of see that it's mobile. On cardiac MRI, PFEs look like a small homogeneous mass with intermediate intensity on T1 weighted imaging and hyperintensity on T2 weighted imaging. A lot of the tumor appearances have been reported regarding signal intensity on late gadolinium enhancement images, and on the CMR sign images, they can be identified as mobile masses that oscillate with every heartbeat. So that's really helpful too. And so here, I think, is a pretty nice picture of a CT. On the left, you see the coronal view and the axial on the right. And these images show kind of like a lobulated mass arising from the right cusp of the aortic valve that did end up being a PFE. So this is actually great CT images of what you could see. And of course, like I stated, they're not always this obvious on CT. Sometimes they're small and more difficult to detect. And then this is a cardiac MRI that you can you see where the arrow is. It shows the mass attached to the mitral valve by a really short stalk. And that ended up being a different PFE that was there on the mitral valve. So, it's not necessarily always clear, but you can see them on CT or cardiac MRI. Okay, so getting into the complication. So even though I mentioned that papillary fibroblastomas are histologically benign, they can result in life-threatening complications. And so this could be really a number of things. Because the PFEs appear to be firmly attached to valvular or mural endocardium, you would think that they're pretty safe, but their extreme mobility causes fragments of the little papillary fronds to kind of enter the systemic circulation. And that's how they cause most of their issues from this embolization. So most of them are located in the left heart, so that increases the risk of systemic embolism. So, of course, they can cause stroke. That's actually the most common thing they cause, something going, a stroke, a TIA, the cerebral and retinal arteries, amaurosis fugax, those kind of things. They can cause acute valvular dysfunction because they are on the valves. They can cause a different embolism like a PE. They can cause VFib or VTAC, sudden cardiac death, and then even MI or angina, because they can occlude the coronary ostia or embolize into the coronary vessels. Since I know I had mentioned they can really be anywhere. They can be right at the ostia of the RCA or the LCA. So if that happens, they can occlude those vessels and cause like an MI picture, cause angina. So there's really a lot of potential complications that can happen, and it's all due to this embolization that can happen from the fronds just breaking off. As I mentioned, because most are on the left side of the heart, systemic emboli is much more common than pulmonary emboli, but pulmonary emboli can be seen from those on the right side, or if there's some kind of like atrial septal defect or something causing abnormal flow. Neurological events, again, are the most common, and to throw it back to our patient, that's how he presented with an acute stroke. And we think that most common, the strokes is like 30% of PFE patients, that's how they present. And just something to kind of hark back on, despite these possible complications and presentations that eventually lead to diagnosis of a PFP, remember that many are completely asymptomatic and are just an incidental finding on a routine echo or something. And that happens in at least 1/3 of patients who end up having a PFE. All right, now into the important stuff, management. What do you do if you find a PFE during a stroke workup, during something else, or you're just reading an echo and you end up finding one in a totally asymptomatic person? So it's really a simple question. The main question is, do you need surgery or do you not need surgery? And so if you do need surgery, a valve-sparing resection is usually what those surgeons will do. More than 80% of them can be treated with just a shave excision. And usually shave excision does very well, and there's no tumor recurrence. More extensive or sessile tumors might require a pericardial patch or reconstruction of the valve leaflet. And then like a valve resection, replacement, or reconstruction is usually not necessary. So generally, the surgeons are able to do a valve-sparing resection as they did in our patient. Now, if you don't do surgery, then generally we just kind of say continued close monitoring to kind of see what's going on. But how do you decide if you do surgery or no surgery? So factors that kind of favor surgery are the following: a history of symptoms or complications related to the tumor, i.e. the embolic events we discussed. So that's kind of obvious. If it's causing issues, if it causes stroke, such as our patient, if it caused an MI, if it caused a PE, if it's, embolizing and causing issues, then that is one sign that we should do surgery. If the tumor is particularly mobile or pedunculated, that makes it just more likely to embolize. If the tumor is increasing in size, then of course it's also more likely to cause issues in the future. That favors surgery as well. And then in asymptomatic patients who have a diagnosis of PFE, who undergo operative cardiac procedures for other reasons, generally the thought is that PFE surgery should be offered. We should offer surgical resection if they're going to get another cardiac procedure, because like I said, it is usually a pretty easy valve sparing surgery that they can do. And if they're already in there, it makes sense. All right, a little bit more about management is the question of anticoagulation. Although thrombi have been reported on the surface of PFEs, there are really no guidelines for evaluating the efficacy of anticoagulation or antiplatelet therapy in affected patients. Once the diagnosis is established, prophylactic anticoagulation therapy is generally thought to be beneficial. So we usually initiate that to guard against thrombi until surgical resection is accomplished. Now, again, we don't always do surgical resection. So in asymptomatic patients or symptomatic patients who are not surgical candidates or refuse surgery, management primarily consists of antiplatelet agents or anticoagulation. And the current opinion appears to favor antiplatelet treatment. And I believe that's because since the most worrisome PFEs are located on the left side of the heart and are not associated with like blood flow stasis, that's why we kind of think antiplatelet treatment is the best option. And again, there's not really clear guidelines on this. This is all kind of expert opinion and what we've seen kind of in the limited cases, what we think works. Okay, and now just a little bit about their recurrence. So the prognosis of PFE is generally very good following the excision. I think I alluded to that in the past, but often when the surgeons do these valve-sparing excisions, recurrence is very, very low. Because of their benign nature, the risk of metastatic spread or recurrence is 1.6 to 3%. And if there is recurrence, it's generally because there was incomplete excision of the tumor at the time of initial surgery. So if they get the whole tumor when they do the first surgery, it's usually a very good course. And so despite this low risk of recurrence, it's generally thought important to pursue post-operative follow-up with TEE for identifying recurrent masses. Again, we don't have a ton of data on this, but about 5 years after resection is generally thought another TEE would be a good time to kind of get it and check for any recurrence or any new masses that could be concerning. And something that I believe I mentioned earlier is that they can come in multiples on multiple valves. Ideally, you will have diagnosed that initially and, you can remove whichever ones you see, but it's always the risk that maybe there was another tiny one somewhere that you missed. So it's good to just kind of in these patients who have gotten excision to follow them up and not let them be lost to follow-up because it is possible to have recurrence, although very rare. All right, so I think I kind of zoomed through that, but thank you all for listening and thank you specifically to Dr. Clemens. He was really integral in helping me learn about papillary fibroblastomas and provide me with some interesting cases and review my slides, so I appreciate that. But I'm happy to answer any questions, any comments, or any thoughts from anybody.
So a couple of things that you already mentioned that they are covered with endothelium. So that makes you think that they have been there long enough to do that, whatever they were, or they maybe been part of the underlying structure and something happened. And this kind of followed some sort of extrusion like. It's hard to know what causes these. I have a little trouble believing that they're related to a thrombotic process. So another thing is, I recall one time when Dr. Guyton took this larger papillary fibroelastoma off that he also said, look what I scraped off. Adjacent to that, there were tiny little, almost like little satellite lesions. So that, when you mentioned recurrence, I suppose you could have a big one and not see the little ones all around it. And the recurrence is because one of the little ones proliferated as time went on. Then as you and I learned when we dealt with this, and they can be in unusual locations, like down in the ventricle on a cord or on a papillary muscle, as your patient was that you showed. So those three things, you already mentioned all of them, but they're in my mind when I see something that looks like a papillary fibroelastoma. Thank you.
Yeah, thank you, Dr. Clemens. That was helpful. And yeah, I agree 100%. Do we know the rate of growth and if there is catheter-based approaches to remove them? Yeah, that's a great question. The rate of growth, generally, I don't know an exact number, but they're benign. They're not thought to grow very fast. They're generally very small and remain very small. That's kind of the general growth pattern for them. I don't know the exact rate, but if one is kind of noted to be getting larger, that's very rare, but that is an indication for surgery. And then if there are catheter-based approaches to remove them, that's a really good question too. I tried to look into that a little, and I mean, maybe there's trials and really, really new things, but I didn't see anything. I didn't see anything kind of that's accepted. Most of it is, through our cardiothoracic surgeons who do an open repair. But I do think it would be interesting if there could be catheter-based approaches to remove them, and probably something that will happen in the future. Billy Joe says guidance on what growth rate per year or size for surgical indication. Yeah, another really good question that I don't have an answer to because there's really no true guidelines for this. A lot of this is expert opinion. A lot of this is case by case. So I don't have like numbers. But as far as like the size for surgical indication, most of them are less than 20 millimeters. So once they get to be bigger, and a lot of the ones I showed were like 1.4 centimeter by 1.2 centimeters, just because those are kind of the interesting ones that end up causing issues and are seen on echo. So once they get to be bigger than like the less than 20 millimeters, they're much more likely to cause issues and cause embolization. But that's not a hard and fast number.
Well, thanks for that presentation. So I looked at when you presented that image on the echo, my initial thought was that could also be a myxoma. Is there a way we could, I guess my question is, based on the when the surgeons excised that mass, the PFE, were there any histological confirmation that was a PFE? And can you really tell that that was not an atrial myxoma, ventricular myxoma?
Yeah, great question. And like I said, myxomas and PFEs are the two most common tumors. So of course, when you think of one, you need to think of the other. And since that was an atypical location for mine, like it wasn't on a valve, like you said, it was in the ventricle, it certainly makes us more likely to think like, could this be a myxoma? And it was larger than most of them are. So I agree with you. If you just look at that, you think that could be a myxoma, certainly. So first, when you're looking at echo, of course, like location, if it's on a valve, it's more likely to be a PFE, but this one was not. But it was excised and it was sent to pathology, and it had the classic pathological findings that I kind of talked about. And so that was how we ultimately how they ultimately diagnosed it as a PFE. It had that kind of papillary configuration, the avascular connective tissue core, and the single layer of endothelial cells. So that's how we knew for sure. I don't know. And, of course, grossly, I didn't see any gross pictures of this one specifically, but I imagine when they looked at it grossly, it had those kind of fronds. and looked like a PFE with that frond-like appearance and that kind of sea anemone thing. But looking at the echo and the fact that this one was in an atypical location, I agree with you 100%. It easily could have been something else like a myxoma.
Thank you very much.
Yeah.
Sophie Stan Sherman, is there clear-cut anticoagulant versus antiplatelet before you do surgery, after you do surgery for a specific amount of time?
Yeah. General consensus is to do anticoagulation before surgery, like until you can get surgery. Really nothing about any anticoagulation after surgery. There was no like time course, no needing it for a few months afterwards or anything like that, just before and then in like the perioperative time. And then as I mentioned, if you can't get surgery, they seem to favor antiplatelet agents for the long term. But again, none of that is really consensus driven. It's all just kind of expert opinion. So I'm not quite sure, but yeah, it seems to be anticoagulation just up until you can get the surgery. And then the risk of embolization is and recurrence is so low, they don't generally think that you need to continue.
Thanks, good talk.
Thank you.
Hi, Sophie. This is Shannon. We had a case at Grady that was interesting when I first started. It was a gentleman who presented with strokes. We did a TEE, and he had this pedunculated lesion on his mitral valve that I thought looked like PFE, but could have possibly been thrombus or vegetation. And so the team went ahead and got a CT scan. And the CT cardiac for thrombus and mass, and that the read on that was vegetation. So they ended up treating him empirically for culture negative endocarditis. And I was a little bit surprised that they I don't know. I think I was surprised that the CT scan said that so definitively when I thought you really couldn't tell from the TE images. So do you know, is there a way, I guess, either based on densities or other like metrics to decide whether something's a thrombus, veg, or a PFE based on with CT or MRI imaging?
Yeah. Yeah, that's a really good question. And yeah, that sounds like an interesting case. So like I said, on the CT, they look like small hypodense masses with irregular borders like attached by a stalk. And you can kind of see the mobility with the EKG gated imaging. I don't know enough to know if I could say that I could definitively like differentiate that from a vegetation, like you said. I'm honestly not quite sure the answer to that. It sounds like maybe the CT readers, whoever read it, kind of had maybe found ways to differentiate those, but I don't know that I could, and I don't know that there's any hard and fast rules or like definitive regulations on what a PFE is on CT versus what would be a thrombus. Of course, there's like the clinical scenario that you consider and the size and the mobility, but I don't personally know how they differentiated that. So I'm with you. I wouldn't have known. I don't know if anyone else like Dr. Clemens knows the answer to that, but if anyone does, please let us know. But I honestly, I'm not sure. Kind of if any of us, besides maybe those who have read a ton, know how to differentiate them on CT when it's kind of that much of a similar picture.
I don't know, Sophie. I'll tell you one reason we don't know a lot about these as far as growth and growth rate and that kind of thing is because most of the time we don't have an opportunity to follow them along. We take them out. So
Yeah,
we
exactly.
do have a couple out here in unusual places. I recall one that was in the main pulmonary artery, and we looked at it over a couple of years, and it didn't seem to change very much. So I'm not sure we have a way to differentiate these from myxoma either in certain situations, like the patient you presented. We were hung up in worrying that this might be myxoma versus PFE, and it turned out to be a PFE.
Yeah, right. And I don't know that, any of us knew that until we had it out and looked at it.
Right.
Right. Well, thank you all for listening. And I hope you all have a great great Friday and great first of the month.
The preceding program is copyrighted by Emory University.